Koch, and today we will be discussing femoral traction splints. So, as you can see, there is no aids or cheat sheets in my room. My computer just showing the recording software. And back to the whiteboard with the unfortunate stickman. Femoral traction splints. What are they? Well, it's kind of in the name. A femoral traction splint is just that. It's a splint that applies traction to the femur from the pelvis, allowing the limb to be put back into its rightful place. So, how did our stickman end up like so? So, most commonly, this sort of injury occurs through a high-energy blunt force lateral impact to the midshaft of the femur. This is most commonly seen in motor vehicle crashes, such as frontal impact in a car, resulting in an up and over trajectory where your thighs are meeting the steering column and not having a good time. Motorcycle crashes, again, frontal impact, up and over trajectory, handlebars v thighs, handlebars win. In this case, our lovely pedestrians, lovely stickman going for a walk, car hits him, he goes up and over the car, ends up with bilateral femur fractures. Oh no, poor stickman. So, how much force is actually required to break your femurs? For the physics people out there, it's roughly about 3 to 4,000 Newton meters of force. For the non-physics people, that's about 300 to 400 kilos of lateral impact, which can be equated to 75 kilo average male in a car with proper safety precautions, so wearing his seatbelt, all that stuff, driving 50 k's down the road, 50 k's an hour down the road, hitting a solid object, again, up over, thighs v steering wheel. So these sort of injuries don't just occur with high energy, it can also happen with low energy impacts. However, that's usually attributed to bone degradation in older generations, such as osteoporosis, malignancies from cancer, or malnutrition, that sort of thing. Also, it can happen through penetration injuries, so like a sheet of steel hitting your thigh can result in a femur fracture. Yeah. Normally, it's uncommon for the femur fracture to be the primary injury. It is more commonly seen as concomitantly to pelvic fractures or injuries, abdominal, thoracic injuries, and distal fractures, dislocations to the leg, distal to the femur. So, pathophysiology. So, what happens? So, as we've discussed, a pretty decent-sized impact to the thigh, but because that impact and that kinetic energy is not just affecting the femur itself, it's also being passed through the surrounding muscle tissue and vasculature. It can result in numerous injuries such as contusions, muscle shearing, vascular damage such as arterial shear, so a bone fragment has cut through the femoral artery, or the bone itself can penetrate the skin. So, what also occurs is because the thigh muscles are so big and strong, and there's a lot of tension in them, they can force the leg as it breaks to rotate externally quite severely. That's because the muscles wrap around the thigh, and then loss of tension, that snaps to the other side. Signs and symptoms. So, back to pathophys. What can also happen is, because of the injury, is massive hemorrhage. So the thigh cavity itself can hold about 1 to 1.5 litres of blood, but again, that's very dependent on the person. Me being 6'8", I can hold a lot more than someone being 5'4". Yeah. So internal hemorrhaging, if there is perforation of the skin, it can be external hemorrhage as well. What can also happen is, because the bone marrow is exposed to the outside tissue, the marrow itself and all the fat inside can be introduced to the bloodstream, and then that can end up being a fat embolus, resulting in a pulmonary embolism. What can also happen from the fluid loss from the vasculature into the cavity is something known as compartment syndrome, where basically the fluid fills up the cavity and prevents any sort of blood flow to the distal part of the limb, from distal from the where the original injury occurred. Okay, so signs and symptoms. What are you looking for? So obvious deformation, because, well, you've just broken a long bone. So obvious deformation of the thigh, whether that be there's like a significant angle, or the bone has perforated the skin, and severe external rotation. There can also be visual changes, so the thigh, like the skin itself, could be darkening in colour from internal hemorrhage, or can be quite tight because of the increased fluid inside of the femoral cavity. What will also happen, there will be a reduction in circulation, or can be a reduction in circulation. So you won't be able to feel pulses in like your dorsipedis or your posterior tibial. A reduction in sensation, so and the inability to move your toes and ankles. So indications. So when is the femoral traction splint indicated? So, like I said, all of the obvious deformation, external rotation, significant localized pain, inability to weight bear. I mean, that one should be pretty obvious. I mean, their legs, obviously they won't be able to weight bear. So equipment. So the most common one used in Queensland ambulance is the Slishman. There is also the CT6, but for the most part we use the Slishman. Both of the traction splints available to us, they operate in very similar ways. However, the way they gain traction is slightly different. The CT6 extends past the foot, and then you pull the pulleys, and that's what's pulling the leg back into position, whereas the Slishman attaches to the ankle, and that's where it gains traction and pulls against the pulls the femur back into place. So how does that all work? Well, first things first, is it indicated? So can you see very obvious deformations, all that sort of stuff that I mentioned previously? Take off, remove clothing to identify the limb. But remember, patients are people. They're not just slabs of meat. They're not just slabs of meat. Everyone has a right to privacy. So obviously we've got to have a look at the limb. There's nothing we can do about that. But once you've had a look and identified, yes, it is just a femoral fracture, then you're good to go ahead. Give them a bit more privacy, so either put a towel or a blanket across their private area, or remains of their clothes, whatever. Then you will go, if it is just a singular fracture, so say for instance just their right leg, go to the left leg, measure the Slishman from the ischial tuberosity to the ankle, and that should be the length you are trying to achieve. If they're both femurs are broken, so bilateral fractures, best guess is usually what you're looking for, so a significant reduction in pain, return of sensation, circulation, that sort of thing. Apologies. So once you've measured the limb, flip it back to the affected side, attach the ankle strap, and then attach it and tighten all of the knobs except for the top one, and then attach the top strap to the ischial tuberosity, so just around the waist, or around the hips, I should say, not the waist, that's a little too high. And then you will see a pull tab. Grab a hold of that and pull. It's pretty self-explanatory from that point. Just get the limbs to the roughly the right length, as close as you can get it. Don't spend 20 minutes finagling trying to get it exactly. Get it as close as you can to ensure there is a significant reduction in pain. You are able to find the circulation, so the pulse pressure the pulse in the dorsipedis, the posterior tibial, capillary fills back under 2 seconds, that sort of thing. Also, the patient should note a significant reduction in pain. At that point, tighten the top knob, wrap up the cord so it doesn't get caught on anything, and then you'll grab your final piece of Velcro and wrap it around the splint and just underneath the knee, and that will assist in just keeping everything locked in and straight. So, complications of a femoral traction splint. So, because the femoral traction splint is a lot less used in the general paramedic world, skill-wise, it has been shown to have a reduction in skill level, because you don't really go to that many femur fractures. I just remembered. Apologies. I just got to skip back to the equipment function. Contraindications. When wouldn't you use a traction splint? Well, you wouldn't use it when, according to Queensland Ambulance Service guidelines, if there is a fracture or dislocation of the knee. It is also recommended to consider potential pelvic fractures or like neck of femur, that sort of thing. So, according to Queensland Ambulance, is purely indicated for fractures of the involving the shaft of the femur. So, if the patient has a, say, neck of femur fracture, there's no point, as long with a mid-shaft fracture, no point putting it on, because there's nothing for the splint to gain traction against, because if this is the neck, it's just going to slide out. Yeah. Again, with pelvic fracture, very similar. Yes, there may be traction, but if the things are fractured, you're just going to cause more injuries. So, jumping back to complications, it can roughly be split up into two separate categories: mechanical and physiological. Mechanical, usually that's the most common one is overtraction. So you pulled it, got it into place, pulled it just too far, and now you're actively causing your patient pain. So how do you realize that there's too much traction? There's no significant reduction in pain. There may be an increase in pain. You're not able to adequately measure the circulation, motor, or sensation. Yeah, so how to fix that? Just release the tension and get it to the point where the patient is no longer feeling that intense, or is reports a significant reduction in pain. Physiologically, compartment syndrome. Because of the fluid filling the femoral cavity, there's not much you can really do on road, so you just sort of got to pray, really, and go as fast and as hard as you can to hospital, because to fix compartment syndrome you need proper surgical procedures. So there is one quick thing I wanted to note is, yes, I've been speaking about compartment syndrome and all that sort of stuff, but haven't really mentioned shock. While it was initially believed that shock does occur with femoral fractures, femoral shaft fractures, that sort of thing, it has been discovered by Ilan Michnik in a 2022 study that of 219 patients studied, 129 had midshaft femur fractures, and of those, they couldn't find a significant link to shock presenting with femoral fractures. Especially something like hypovolemic shock, that's more common in polytrauma, so your bilateral femur and pelvic fracture. I would like to thank you for allowing me to preach and state all my findings on the femoral traction splint, and I apologize for rambling so much. Thank you, and have a good day.